Need to move on. We're a bit delayed. Thank you for an excellent presentation.
Thank you.
And to put these talks into perspective, we have this summary by Dr. Minetta Liu, who is in person, yes. She's from the Mayo Clinic and will be discussing the last several studies on circulating DNA. Dr. Liu.
Thank you. Dear Dr. Carey and Dr. Brown, and all of you here in person and virtually, thank you for your attention, first of all. I wanted to thank the meeting organizers, and Dr. Kaklamani and Dr. Artiega, for giving me the opportunity to give some context to the very important presentations that you just heard from Drs. Bedard, Turner, and Bianchini. These are my financial disclosures. Over the past couple of decades, there's been an explosion of blood-based biomarkers. And those blood-based biomarkers allow us to fit for purpose in a variety of clinical scenarios across the cancer spectrum. Clearly in metastatic disease, to assist in drug selection, to facilitate assessments of prognosis, monitoring response, and even predicting resistance. We can now, because of increased sensitivity of these various assays, also look in early stage disease, where other issues like detection of minimal residual disease after definitive local and systemic therapy, or looking for the emergence of molecular relapse over the course of time become very important considerations. We're now even in the era of using multi-cancer blood-based early detection. There are several circulating tumor-derived factors that can be assessed. They include circulating tumor cells, circulating tumor DNA, and extracellular vesicles. All three presentations focused on circulating tumor DNA. ctDNA detection is looking for tumor-specific DNA amongst cell-free DNA in the peripheral blood. What we've learned as more and more studies have been performed is that ctDNA varies across malignancies and also by tumor burden and division by stage in terms of localized versus systemic disease. So ctDNA shedding varies across tumor types and correlates with tumor burden in biology. And the sensitivity of detection is critical, particularly as we inch closer and closer to early stage disease, and again, even early detection. The two primary modalities used to evaluate ctDNA are PCR and next-generation sequencing. PCR is really useful for looking at specific somatic mutations. It's very sensitive. It can be very quantitative and reliably quantitative, but it's very limited in multiplexing or combining alterations. There's a rapid turnaround time and it's relatively inexpensive. At the other end of the spectrum is next-generation sequencing, which allows us to look at multiple different types of alterations, but the sensitivity is limited by error rate. It's more qualitative, although efforts are being made towards improved quantitation, excellent multiplexing of up to over 500 genes, longer turnaround time, and certainly more expensive. The more you look for, the longer it takes and the more it costs. There are a variety of commercial assays that are available for solid tumors. They're listed here. The majority are strictly blood-based, represented in the blue. There are a couple that are tumor-informed. In other words, sequencing is done of tumor to identify specific alterations, then to be tracked in individualized blood-based assays. Just for your reference, I'm not going to go through the next two tables, but these are just some of the metrics with the variety of assays. They range in terms of the number of genes, types of blood tubes that are collected. They can be used for clinical genomic profiling or even in monitoring for early stage tumors. We're going to focus on three very important abstracts this morning, or this afternoon, depending on where you are in the world. In metastatic disease, we have the BioItaly study that looks in prognosis predominantly and monitoring response in the metastatic setting. The PADO-1 trial looking at the prediction of resistance. And then in early stage disease, the C-TRAC triple negative trial looking at the detection of molecular relapse. So with BioItaly, as you just heard, this is looking at the use of an aromatase inhibitor and ribociclib in first-line therapy for hormone receptor-positive, HER2-negative metastatic breast cancer. Blood was collected at baseline, cycle 1, day 15, at cycle 2, day 1, and then at first imaging approximately 3 months later. Blood collections were relatively successful in terms of the number of patients from whom blood was successfully collected. CTD analysis here was achieved using a next-generation sequencing assay for 39 genes. Importantly, the target mutations were defined as signal nucleotide variants or insertions and deletions detected at day 0. If there were multiple alterations identified, one was selected for subsequent monitoring, and that was selected based on the allele frequencies. The absence of a target mutation at baseline was associated with an excellent prognosis. The absence of a post-baseline detectable mutation was associated with the lower risk of progression. Those who had persistent absence of a mutation did particularly well. Those who had no mutation identified at baseline, who subsequently developed a mutation later on, had a worse prognosis than those who had, again, a persistent absence. Importantly, day 15 seemed to be the most valuable time point evaluated. Patients who did not have a target mutation at day 15 had an extremely favorable outcome. So the question is, do you just look at day 15? Should we just look at a one-time value? And importantly, a comparison of baseline versus day 15 shows that you can further stratify outcomes based on what happens at baseline presence or absence versus presence or absence at day 15. So circulating tumor DNA here was evaluated using a next-generation sequencing-based assay in the peripheral blood, baseline, cycle 1, day 15, cycle 2, day 1, and first imaging. Positive ctDNA was defined by a single baseline alteration with the highest variant allele frequency. The summary of findings is that the presence of a targetable alteration at baseline appears to be a negative prognostic factor in hormone receptor-positive, HER2-negative first-line advanced breast cancer. Clearance of that alteration is associated with the lower risk of disease progression, and detection after baseline is associated with the higher risk of disease progression. Cycle 1, day 15 is a critical time point in this particular patient population. If you think about this further, these findings do provide further clinical validation of the prognostic power of ctDNA detection. We see this time and time again across clinical studies. The emergence of a detectable ctDNA after treatment initiation was associated with the higher risk of disease progression. The question is, if additional alterations developed, what happened, right? We were tracking a single alteration over the course of time. And were those ctDNA mutations themselves clinically significant? Again, here we're simply looking at presence or absence, but the specifics may be critical in our understanding. We'll turn our attention to PADO-1. This was an interventional study where ctDNA detection was used to make a treatment decision. In first-line therapy for hormone receptor-positive, HER2-negative breast cancer, all patients were starting an aromatase inhibitor and palbociclib, and blood was drawn at the start of treatment at 1 month and then every 2 months thereafter. And those who developed a rising ESR1 alteration in blood and who, upon staging, had no clinical radiographic evidence of disease progression were randomized to either continue the aromatase inhibitor or switch to fulvestrant, both groups continuing palbociclib in the background. Critically, those individuals who were randomized to continue the aromatase inhibitor and palbociclib were given the option to switch over to fulvestrant palbociclib after overt disease progression. The median time from inclusion to detection of a rising ESR1 alteration was 14.2 months. And I think it's critical for us to understand here that rising is not necessarily quantitatively increasing in number as it is detection of the ESR1 mutation. And I think that's a distinction that we need to be made clear as we think about the data here. In total, 172 of the patients were randomized. With a median follow-up of 26 months, those individuals who switched therapy based on the emergence of a resistance alteration, the ESR1 mutations, had an improved prognosis by switching to fulvestrant. Again, I think the critical part of this study was also that switchover. It was very thoughtful for the trial team to think about including this crossover because you want to include all therapy as opposed to just looking at what happens with that initial switch. There was a 6.2-month benefit for the switch to fulvestrant versus continuing AI at stage 2. and then a 3.5-month benefit for those individuals who stayed on the aromatase inhibitor and then subsequently switched to fulvestrant on disease progression. Here it was a ddPCR-based assay for cell-free DNA for looking specifically at the clinically relevant ESR1 mutations. Blood was collected at baseline month 1 and then every 2 months for patients who started initial therapy. So a rising mutation here prompted the switch from AI palbociclib to fulvestrant palbociclib, despite the absence of clinical or radiographic disease progression or hormone receptor positive HER2 negative disease. So what this is trying to answer is switching based on sort of molecular progression as opposed to overt progression. Is that in fact going to improve outcomes for our patients? And this switch was associated with an improved median progression-free survival without any new safety signals. What are some questions? Well, these findings do support serial ctDNA monitoring as a means to identify and react to treatment resistance as soon as possible. But whether the strategy really will translate into a meaningful overall survival benefit remains to be demonstrated. The potential to avoid disease-related symptoms with an earlier change in therapy does need to be explored. Patient-reported outcomes were collected, but we don't have those results yet. And if you think about that less than 3-month progression-free survival benefit by switching from the AI palbociclib to fulvestrant palbociclib earlier based on the mutation, that needs to be balanced by quality of life and resource considerations, right, with respect to oral versus intramuscular drug administration. We do have these answers in terms of participants who were detected versus not detected at baseline. We need to consider the technical considerations of this assay in terms of what thresholds were used to define what rising is or what presence or absence were. There will be work, I believe, done looking at next generation sequencing as a means to identify these alterations and whether or not that will be more useful in the broader context because we'll be able to look at other alterations needs to be seen. And then the third abstract is C-track triple negative. So again, this is in the adjuvant setting, early stage hormone receptor negative, HER2 negative, early stage disease, a tumor-informed assay where tumor was used, sequenced, and then 1 or 2 alterations identified for subsequent tracking in a personalized blood test. The blood test was then used for active ctDNA surveillance at baseline and then every 3 months. And in those individuals who had ctDNA detected, they were randomized to either intervention with pembrolizumab or observation. But upon randomization, staging was done. If that staging identified overt disease recurrence, then those patients went on to standard therapy. In total, there were 208 patients registered. An assay was developed in 171 patients, and 161 were able to continue on to ctDNA surveillance. This looked at a high-risk as well as moderate-risk patient population. The median follow-up in the study was 20 months. All these individuals completed active surveillance. Of those who had ctDNA positive by the 12-month time point, they're illustrated in the Kaplan-Meier curves on the left. It was approximately 27% of those individuals. Those with higher risk disease were more likely to have ctDNA detected by that time. Of those individuals who had ctDNA detected and entered into the therapeutic trial, 72% of those individuals had overt clinical or radiographic evidence of recurrence at that time. So these were patients who might not have had staging otherwise, so at least the blood triggered identification of metastatic disease, but this didn't necessarily identify molecular relapse versus overt relapse. 9 individuals with ctDNA positive and negative staging could have started pembrolizumab. Only 5 of them did, for reasons that were outlined. For the group that was in observation, there were 14 in the observation group. 1 by protocol definition did go on to therapy, so there were 13 that were strictly observed, and 4 of them actually continued ctDNA surveillance for up to 24 months without any evidence of disease. This is a ddPCR-based cell-free DNA analysis for 1 to 2 mutations that were selected on the basis of clinical tumor profiling. And this was performed on blood collected in early stage disease every 3 months for up to 18 to 24 months. So ctDNA monitoring is feasible during adjuvant therapy, and the authors should be applauded for their ability to do this despite the pandemic. Relatively few patients, though, initiated therapy for appropriate reasons. So this does preclude the assessment of acting on that ctDNA result, but it does open the door for consideration for other studies. Here, a tumor-informed assay was used to improve the sensitivity of ctDNA detection, but only 1 to 2 alterations were tracked. Certainly, that meant that because of that the sensitivity was not as good, that most of the ctDNA positive participants, in fact, had overt disease progression, and we need more sensitive assays to truly look for molecular recurrence. The frequency of sampling and the timing of setting remains to be seen. So what have we learned? Different disease settings require different approaches to ctDNA detection. You can look at specific selected mutations if the point of looking at circulating tumor DNA is for drug selection or identifying pre-specified mechanisms of treatment resistance. But perhaps we should be looking at patterns of genomic alterations as opposed to selected mutations if we're looking strictly for the detection of ctDNA. Whether we're qualitatively identifying or quantitatively measuring ctDNA is a careful consideration across the spectrum of cancer. And to improve the sensitivity of ctDNA detection, it's not just about better assays, but it's about looking at multiple different analytes. And with improvements in technology, we will have the ability to multiplex for more alterations, looking for rearrangements in addition to mutations. Methylation patterns and fragmentation patterns are also coming forward. At Mayo Clinic, we focused on looking at rearrangements, so doing a tumor-informed assay, looking at gene rearrangements, and then specifically developing a plasma-based assay for the DNA junctions unique to that tumor. This is a patient with HER2-positive disease where 2 junctions were selected for monitoring. This is a patient with advanced disease where everything, including CA2729, was dropping with the treatment with afatinib on a study. But then the 2 different junctions varied, and 1 junction actually tracked with extracranial disease, where she had a complete clinical and radiographic response, but at the same time she developed leptomeningeal disease at that time when the other junction was rising. There are multiple patterns of alterations that can be identified, and they're just listed here. And I just want to congratulate the 3 authors again for their very excellent presentations. Thank you very much.
Thank you very much for that discussion.